It's my pleasure to introduce our guest today at our SCCTSI Career Development Seminar Series, Dr. Monique L. Snowden, who's Provost and Senior Vice President of Fielding Graduate University and Faculty of USC Equity Institutes. Today, she's going to be talking to us and hopefully having a conversation with us about leveraging racial equity data in research. Thank you, Dr. Snowden, for being with us today.
Thank you. So let's go ahead and get into this. Sorry. So I know that we had the learning objectives posted, but I just want to go over them just really briefly and then talk a little bit about sort of just some rules for engagement as we get ready to spend the next 2 hours together. First of all, we're going to go over some constructs of unconscious and implicit bias, talking about the differences between those two, leaning into this notion of equity mindedness. What is it, and how's that germane to CTS? And then we'll also talk a little bit about algorithmic biases and what algorithmic equity is all about. And then lastly, we want to wholly be able to critically examine sort of structural racism as it occurs through data, presentations, and algorithms in our actions and practices. So that basically lays out what we're going to try to accomplish here today by the end of the 2 hours. I wanted to, establish just a few little ground rules. I think that usually helps when we're talking about particularly diversity, equity, and inclusion matters. First of all, since you've all committed to being here, I say be present as much as you possibly can. I do realize that with our current situations, many of us working at home, there may be things that kind of pull you away, but as you are able to, please come back in and lean back in. And then also I ask that we all attempt to exercise engaged humility. And what I mean by that, the scholars Sensor and D'Angelo talk about identifying where your learning edges are and trying to push those. And the example here is whenever you think, maybe I provide some information and you may think, I already know this, I've heard this before, then ask yourself, how can I take this deeper? How can I apply it in practice, in a different way? And so what can I do about bringing this together with what other individuals may share here today to deepen and broaden my perspective and my knowledge? And that's what we mean by engaging in these types of sessions with humility. So let's jump in. First, I'd like to go ahead and see who's in the room, if you will. So I have a short little poll here, and I'm going to launch it right now. And so if you can all assist me in going ahead and answering the poll. Okay, so I'm just going ahead and share the poll results here. So we see we have about 46% of the folks on the in the webinar today are from the Keck School of Medicine, followed by Children's Hospital of LA and Ostral School of Dentistry. And also we got some folks from School of Social Work, and then about 6 folks who are from another particular area. If those who answered other, could you do me the favor of, and for the good of the group, could you please maybe type in the chat what affiliation you are with, so that we can kind of get a sense of that? I would really appreciate it. Thank you, Lois. Anyone else who noted other? Thanks, Sarah. Scott from School Pharmacy, glad to have you. Anyone else? Chan Division of Occupational Therapy. Is that, I think, is that pronounced Lamoni?
Lamani.
Lamani. Thank you, Lamani. Okay, so it's always good to, when we're getting ready to start something, particularly a session dealing with diversity and equity issues, to see who's in the room, because what we know is that we're going to come with different perspectives, not only from our own personal experience, but occupational experiences and where we might be situated in our profession and in our organizational context, as those are going to, in many ways, guide and shape some of the ways in which we think, some of the practices that we enact, And so we really like to really understand sort of like where we're all coming from. So I always like to start with who's in the room, and that perhaps will help too as we are going to do some breakouts here. So let me give you a little preview of what to expect in the next 2 hours. First of all, at the top of the hour, around 4 o'clock, we will be doing a breakout at that time. So for the first hour, I'm going to be covering some material. There is going to be some opportunities there for us to do some engaging. The group that we have together here, it looks like we have 35 participants. So we have a group that's small enough for us to actually have individuals be able to speak if they desire to. But I do ask for you to engage in the chat. Karen is going to do us the favor at the end of the webinar and actually save the chat so that she can share it with participants, as we'll be sharing some thoughts and ideas in the chat. And it'll be great to have a record of that for you to be able to use and go back to for your own thinking, and also in sharing with your colleagues as you engage in diversity, equity, inclusion work together. Then after the breakout will be about 20 minutes, and then we will come back and then we'll do some sharing of some of the things that you spoke about in the breakout. And then for the next 25 minutes, we'll actually engage in some more information and have some opportunity to also engage in chat around some relevant research. So that really sets the stage for what we're going to do in the next 2 hours. Some of you may have seen this. This was an article that was, you can see at the bottom. I've tried to put here for those of you, you'll get the slides in epidemiology about what is the Episcope. And I like to start with this because today we're going to be talking about implicit and unconscious bias, and particularly as it relates to racial in racial context. But as many of us as researchers and scholars, we already have a concept around causation, and particularly as it relates to bias. So I wanted to start off with talking about the bias that we typically are engaged with as researchers, because we're going to be leaning into bias in a different context. But it's good for us to start from where we're at, because in many ways, these biases here as researchers, they actually become more confounded when we start adding in racialized perspectives. So in the Episcope here, and as you can see, you see the individual here in front of the what is like a telescope. And what we're looking through is that these are the many layers and filters of which bias is occurring at every level. So when we look at this individual, they're trying to get out to this point A agency at the top here. And that's sort of like, our interaction with nature, with the natural world. And so between us as researchers in the natural world are all these layers where different biases may enter in and distort that natural world and how we then see it. We know that as researchers, we're typically dealing with notions of internal validity and statistical reliability as we move through design, analysis, reporting, and interpretation stages of our research. And we may engage in certain types of biases as it relates to moving from, let's say, population to study participants, where we'll have potentially selection bias, and then study participants to data when we're dealing with information bias. And then from data to study findings, we're dealing with those confounded matters when things are coming together. So this here is just to start us off with saying that, bias is caused, right? At the core of it, causation is there. And so as we get ready to lean into talking about bias from a diversity, equity, and inclusion perspective, we need to understand that we bring into it already our perceptions through those lenses that we're looking through. And as researchers, it really is interesting for me to really look at each of these stages and say, when am I most susceptible to certain types of biases when it comes to implicit or unconscious bias. So this is just to start us off with saying that we already have a base for talking about bias, but we're going to shift and talk about it in a different way today. So let's setting a racial context for our conversation today. The Pew Research Center shares this data, what we know is that we have what we call the browning and the graying of America. We see more diverse population, and we know that individuals are living longer, although we know that there are some changes in what we're going to see in that data based upon the many unfortunate deaths that we've seen through COVID pandemic. But here's some data that basically shows us that in 1965, 84% of the American population is white. And as we move to 2025, we're going to see that be 60. And so we'll see that 60-40 split. And then when we get to 2065, we're going to see the non-white actually transcend above the white population. And this is really important for us to set this racial context, because why is it germane for us to be having these conversations about things like implicit bias and racial bias? What we're going to see is in our society, particularly here in the US, as these data are grounded in an American perspective of what's happening, we're going to see that this is going to become more and more an issue, right? And so as practitioners, as researchers, we need to be cognizant of the fact that what is the current state of affairs as it relates to certain populations and the disparities that we see, if we don't do something about these things and do it in a diligent and in a sound way, then more and more people in our population are going to find themselves on, let's just say, on the wrong end of treatment of various aspects from in the translational process. So what's in the headlines and in the minds? Just give you a few minutes to just read a couple of these headlines yourself, but I'll just point out a couple things. Some of the things striking to me is like at the top here, when we talk about what's happening in the Chicago area, this notion of Black being a pre-existing condition, right? Moving over to how we're seeing various aspects when it comes to women of color and babies and the mortality rates and what we see in the disparity there. The notion here at the bottom that, people not feeling as though that they're believed when they come into the ER and facing more, unfortunately, discrimination. And this is what we was stated as. And then also just seeing certain things happen in clinical trials. So these are, I say in the headlines, some of these things are coming from the headlines like a New York Times, some are coming from journals like the American Journal of Managed Care, and others are coming in social media and everything. And so wherever the headlines are, whether it be in something more of a trade magazine or an academic journal, or even social media, it's in the minds of people. So the headlines then come and then they get entrenched into the minds. And so this is what people see, and therefore it starts to influence what they believe. And when that starts to happen, it starts to influence how they actually perceive they're being treated or how they're treating others. So headlines and in the minds. So let's move to unconscious bias and implicit bias. So looking at these headlines, there's this notion of unconscious bias, right? And unconscious bias is when you're operating outside a certain awareness, and this unawareness could be in direct contradiction to actually what you believe and what your values are, and it may affect sort of your interactions and decision making in various aspects. Now we move to implicit bias, sort of moving into more of that subconscious kind of state where you actually know, you have an awareness, but it isn't always top of mind, right? It's sort of subvert, right, underneath the surface. But the important thing here is the last part of this, is that as individuals are being made increasingly aware of their biases, they're still laying there under the surface. And while they're under the surface like that in this sort of subconscious area, this is when it becomes more difficult for us to be intentional in our actions as it relates to how do we mitigate these types of biases as they enter into, in this context, in the clinical and translational science processes. So I wanted you to go to the chat and see if anyone, IAT stands for those of you who don't know, implicit association tests. So there are a number, these tests have been, they've been out for decades, and you may have engaged in one maybe in your, not only in your professional context, but maybe in your educational context. So I was wondering if folks could share in the chat if they've ever taken an implicit association test. These would be one of those tests where it's giving you sort of maybe a statement about a Black person and then a white person, and then trying to see if there's any differences. So can you share in the chat with us so Natalia, you have, yes. So many of us have had, and I've been through a couple of them as well. So folks are sharing that they have. Could you share in the chat whether you felt like, those of you who said yes, could you share in the chat whether it was a good experience, or did you feel like that, what came of it? Did you have any behavioral changes or any practice changes that you might want to share with us? For those of you who might want to share via voice, then if you could raise your hand, then we can go ahead and call on you. But if you don't feel comfortable with that, please just share in the chat. And those of you, while individuals may be sharing that, for those of you who said no, there's you can do a Google. I think Yale has a number of them that you can do. And there are many different types of them out there, but you can Google implicit association tests and actually take one. I say all data is useful in some particular way. And I think that for many of us who may have taken them, it may have revealed some things that we weren't quite aware of, top of mind. So these implicit association tests are trying to get at sort of those underlying biases. And one of the things that we know is that, bias can occur at various levels. The effects which lead to prejudice, cognition, stereotypes, and behavior, which then can lead to actions of discrimination. And when we are experiencing these particular biases that we're not necessarily cognizant of, when we do become aware of them, then in some ways they kind of start to move into a different space of potentially subconscious racism, right? And so that's why we want to be really cognizant of the fact that, we have to move outside of the realm of sort of that unconscious bias and start to try to find tools and ways to get at least getting to that implicit level so that we can get into the action level of actually doing something about it. So here's an exemplar. I know many of you may be aware of, this notion of the conscious mind, the subconscious mind, and the unconscious mind. And there's, the iceberg metaphor here. And what we see in this one here, this one actually, and I have this reference down at the bottom for you. This was about lung cancer disparities, right? And talking about the healthcare delivery and what may be in, systemic and institutional racism that's involved. So what you see here is sort of moving from the conscious mind down to sort of the unconscious mind, where you start to see in the middle here, which is really below the surface of the water, right? So below the conscious mind, these racial and ethnic minorities. Then you also have underneath of that, medically underserved, and then hidden populations down at the bottom. And so the iceberg from implicit bias standpoint of understanding sort of what's the distinctions between unconscious to conscious, this provides a really nice metaphor for you to be able to kind of walk through that. Let's stop right here and see if there's anything that folks would like to ask or share about the information shared thus far. Okay, no problem. We're going to go ahead and move on to the next slide. So here's where on the next three slides is some relevant research, and here's where I'm going to ask you to kind of take a look at some of these. What I have is a citation for you, and then some of the findings here for this particular search. This is where I'm going to ask you to kind of bring your voice in for us to do some engaging around this and see what people's initial kind of take on this is, and if you are familiar with this research or research like this, or if you're engaging in this research, and for us to have some conversation about this. So this particular study, entitled Implicit Racial Ethnic Bias Among Healthcare Professionals and Its Influence on Healthcare Outcomes. This was a systematic review. And here's some of the discussion in these that came forth in this study. Basically, the level of implicit bias against these individuals of color or dark-skinned people were relatively similar across the different groups. And then the implicit bias was significantly related to patient-provider interactions. And then you can see the rest of the things there. I'll let you go ahead and read that yourself. Okay, so let's see if we can get some voices into the room here. I'd like to hear a little bit from you. Now, as I stated early on, it's not that we're not coming across a lot of this stuff for the first time. But what we have is an opportunity here today to really talk about it, and to talk about whether, our experiences and what we think that we can do, not only as practitioners, but researchers, as it relates to these particular, let's just say, these particular matters that are coming up on this particular study. So would anybody like to react to these particular two, let's just say, discussion points or findings in this study?
I'll share.
Thank you.
Well, thank you so much, Dr. Snowden, for this talk. I know it can be kind of intimidating to talk to a bunch of empty Zoom faces. So I will say this is not my area of expertise in terms of, I don't look at research in terms of in healthcare setting or any work with healthcare professionals and healthcare workers, but from lived experience, I'm not surprised at these findings. For some of this, either ourselves or family members that we have taken to these systems, we have experienced this. And so from that positionality, it's not surprising when I see headlines like this, because it brings me back to either childhood or even recent memories of having to navigate some of these systems. And for me, I've oftentimes felt when I've gone, especially these patient-provider interactions, when I've gone, I guess the point I'm getting at is I didn't feel seen by healthcare professionals until I said, I am a PhD, I know what I'm talking about. And I think in these conversations with friends and stuff, it's a matter of, we shouldn't have to show our credentials and show that we aren't there are people that may not know about healthcare systems to be heard and our health taken for valid concerns.
Thank you. And how you pronounce your name? Yoshira?
Yes, but I go by Yoshi.
Yoshi? Thank you, Yoshi. And thank you for bringing in the notion of lived experiences. So my understanding, and I'll for full disclosure, I'm clinical translation sciences is not my particular area, right? But as I leaned into this research and started reading up on what actually it involves, I think that it involves closing the loop with the community. And so when we start talking about our lived experiences, we are that community, right? And so as a Black woman, as I look at this, my first thing is that it's very personal to me, because, I'm represented in this group. And so thinking about that and what does that mean, I can tell you my first reaction is, I know that from my own lived experience, but not being Hispanic, Latino, or Latina, I then thought about, there are other groups that may be similarly situated or similarly experiencing certain things that I experience or that my family experienced that I'm not necessarily fully cognizant of. it made me wonder, what are some of the differences and what are some of the similarities of those particular experiences. And so I was really interested to then see and take a look at some studies as it related to what is the Latina experience, and how might that experience be very much similar to mine, and then create this really convergent point, and maybe that then allows me within my community to see that there are other individuals that I could be, let's just say, engaging around the discussion and actions around this that aren't just simply my race group. Anybody else want to share? Particularly, you know, I'm really interested in perhaps hearing from some individuals who might be able to speak to the second point, who may be, if they are health providers, and what might be some of those patient provider interactions that they may have witnessed or that they may have experienced themselves on the caregiver side. Sorry about that. Yes, Elizabeth, please.
Hi, I think, so I actually clinically work in the emergency department. So I think we see a lot of, everything's on display in the emergency department, how everyone acts and how everyone is involved with each other. And over the time that I've been at the county hospital, I definitely have seen a change in provider awareness of how they're treating people. But I also has made me more aware of like the things that I used to say or do when I was an intern just out of medical school, and how I mean, I guess biased is the term, right? Like the assumptions I would make and how that would interact with like how I would present patients to my attendings. And like, I really appreciate the opportunity to kind of think through this a little more, because I think as now, you know, I teach junior clinicians or I'm involved in other educational settings, like those words that don't necessarily have a bad connotation on their own, but you know what people mean by them, like being able to like recognize those of like, we need to probably address that, you know, like we need to not just let that slip by. And I think it's just a difficult thing to get through. I think it's a difficult conversation to have sometimes too, like, because it's about yourself and like recognizing things that you don't like about yourself, like that you would think that way, I guess, but also how to approach that with like someone that you're interacting with or working with without, you know, kind of destroying the rest of the day, I guess is the way to put it. Just like, you know, anticipating their emotional reaction to that. So, cause like I see that and I know it's true. Like, I know that this is true and I'm like, but I don't know what to do to address that in my like own practice.
Right. Well, I think that one of the things to think about is that, you know, there's a certain level of discomfort that is necessary, you know, comes with growth, right? And how can we, you know, how can we sort of accept the discomfort while we strive for the growth, right? And then I think that one of the things I heard you say was that your responsibility for training others. And so it really becomes even more important that we start understanding sort of where we stand, so that when we're working with others, we can help them, right? So thank you. I really appreciate you sharing, Elizabeth. Makisha, I think I saw you raise your hand. Would you like to step in here?
Yes. Hi, everyone. I'm just so grateful, Dr. Snowden, for this conference today. I really appreciate it. I am not in the healthcare field. I'm actually at a research center, and I'm on the operations side of the research house. But I definitely appreciate both Yoshi and Elizabeth sharing the experiences that they have. And I identify as a Black woman. And when I was reading that under the second bullet, the final sentence about the attitudes, it just takes me as far as personally thinking about when you go into a healthcare facility, whether it be emergency, a doctor's office, the trust that you must have to even get to that point. And particularly being a Black person and there being things that have happened to my community in the past in the healthcare field, it takes a lot of trust for anyone I feel like of any color to go into healthcare facility for treatment, but specifically for my community itself. So just the trust factor holistically as well, not only from the doctor providing the treatment, but from the moment you step into the facility, from the person checking you in to whoever else is involved in that, I think is very important. So I really do especially appreciate Elizabeth talking about that in emergency room situation, because I can only imagine you have to move very quickly and you have limited time for decision making, but this is very important that we talk about this for that. So thank you so much.
You're welcome. And when you get the slides, one of the things in one of those headlines was there actually was a headline there about all I want is to be believed, sick with COVID-19 and facing racial bias in the ER. This notion, Keisha, as you're talking about, of trust, I think one of the things we have to think about, and I'm gonna move to this to the next research one. You can read that while I'm talking. One of the things we have to think about is that inherently an individual is in a vulnerable situation when they're moving into a healthcare space. My PhD is in communication and dealing with basically this particular study talks about oncologists and communication. And you have to think that, first of all, the individual is already dealing with the vulnerability of just being in sort of this one down situation. And I know we often don't think about it that way, but, and this happens when we're, even in college, we see our professors as being someone who's really knowledgeable and they're one up. Well, even with the internet and I can Google everything or whatever, when you go into a healthcare facility, or you're dealing with a doctor, or you're dealing with any person who works for that facility, even at the front desk when they're checking you in, there's this sort of like you regress. My own feelings is this kind of regression that all of a sudden that, yes, I am a person with a lot of education, but I don't, I have to trust. Trust is so important there in the communication from the individual, from the entry point into a facility, into then perhaps even talking with your doctor. And then if you are getting, if you're having some health issue, or you're getting bad news or anything like that, then that communication every step of the way starts to be something that can be empowering in some ways, or it can be debilitating. And I think that we have to be cognizant of the fact that our biases, as they kind of come to the surface, and how we treat different individuals because of our perceptions about a particular group, or a particular, let's just say, even someone coming to the desk and assuming that someone may be homeless, or a lot of those various things that kind of enter into, that's going to shape that interaction. And let's just say it's right there when I'm just checking in. I'm going to carry that with me when I go back behind the doors. And then that, one of the things that we know that happens is that it's not the one, they call it, sort of insult by, 10,000 paper cuts. It's not the first cut, second cut, third cut. And so all along, people are feeling these little slices, nothing that basically can totally damage them in that one particular moment. But you take that all together as a whole, and it becomes how individuals then experience a system, not just simply just individuals in the system. So this particular study here is the effects of oncologists, implicit racial bias, and racially discordant oncology interactions, specifically talking about communication and the role that communication plays in actually how people feel relative to these interactions, and then what may end up translating into racial treatment disparities. So don't know if anybody would like to, kind of speak to this. I know that, oncology as an area, there may be, I don't know if we have some folks in here who might have some experience with oncology, or so want to give you opportunity, either raise your hand or put in the chat if there's anything you want to share about this. I'm reading that Catherine wrote something in the chat here a few minutes ago I'm not a provider, but I've read in the news that patients of color are under-prescribed pain medication when they really need it. Thank you, Catherine, for putting that in the chat. I like to call out, when we start talking about medication in, medication, there was a particular study that I read that was about UK and pharmacists. I'll make sure that I share that citation with Karen to send out with other materials. You might find that interesting, Catherine. It was an interesting study. It has some qualitative information. There's some vignettes from individuals as they were grappling with who was actually prescribed medication and who wasn't, and some of the bias that played out in that particular research study. Okay, so I have one other study here that I want to share with you, and this one here is actually really related to clinical and translational frameworks. It's a call for grounding implicit bias training in clinical and translational frameworks. A really interesting study that said that perhaps the framework of clinical translation, the clinical and translational framework itself might actually be a framework for looking at how to get at implicit bias and associated training. So interesting in this study in particular was that it referred to the prejudicial attitudes towards stereotypical beliefs. And this one here pushed things a little further than sometimes we see, and says that prejudicial attitudes and stereotype beliefs are activated spontaneously and effortlessly, often resulting in discriminatory behaviors. A lot of times, like I said here, often we'll use the term, a bias really broadly and not differentiate between prejudice and stereotyping. And then also this last point, literature on health disparities focuses primarily on implicit prejudice, right? And few studies have systematically investigated the role of implicit stereotyping in patient care. And I think it's really important for us as not only as basically recipients of healthcare and providers of, and also at those who are working in a research context, that we make distinctions between certain constructs, right? Stereotyping, prejudicial attitudes, and discriminatory behaviors, all operating in, these are different constructs in our need to understand how we sometimes gloss over certain things by using the same terminology to apply to different things. And I think that this is really important. This nuance around this is really important for us to get underneath, some of the things that are happening and push that up above that surface and that metaphor of the iceberg, pushing it up to the surface level so that we can see these things and that they become more explicit, and that in many ways that we cannot deny or reject that they're actually happening. So any thoughts about this one here or questions? Okay. All right, so what I presented to you is three relevant types of studies that you could reference, look at, and also reflect on and think about. I think that intuitively we know certain things, experientially we know certain things, but to the point of engaging in that humility that I talked about a little bit earlier, think about these things and push yourself beyond. If it basically is something that you experience in your own personal life, like Markeisha shared, think about what you might be able to do to just to go a little bit deeper, perhaps read a study to see how that kind of plays out. If this is more from a research perspective, then really coming into a space of understanding how people's lived experiences and how that plays out for them. So this is one of the ways that you can expand sort of your own understanding and deepen your understanding. And really, the best way for us to get at a lot of these things that are happening is for us to engage in dialogue and to be willing to go ahead and lean into spaces that are not as comfortable for us, or maybe not as resonant to us, but can help us be able to broaden and deepen our understanding, first of self and then of others. So let's talk about some strategies, right? Here's some strategies to mitigate implicit bias. So this here particular, I've got a particular citation here for you from the Journal of Infectious Diseases. And what these researchers kind of came up with is how to perhaps recognize and mitigate and create some strategies at 3 levels: the organizational level, the individual level, and then looking at both. So this notion of at the organizational level. So for our employers, for the hospitals that you work for, the research entities that you work for, whatever that organizational context in which you're operating in, at the top of it, leadership needs to be committed to the cultural change. They need to be committed to understanding that there is something that needs to change. And so that commitment is first and foremost most important at that organizational level. They can also provide meaningful diversity trainings and mentor programs, CTSI doing these webinars and having their educational series and things like that. So always making sure that there's some educational components that may be available to individuals to come learn more, to go deeper in their learning and have that accessible. And not just simply, because it's episodic, because we're experiencing racial tension right now or whatever, but we know that health disparities didn't show up during COVID-19. It may be more visible to folks because we've now attached that to basically mortality, and we've attached that to seeing so much in the news about it or whatever. But this is one of the things that comes out of this that is able to affect the change, is that more people are becoming aware. And what has been interesting to me is that some people are becoming aware that there are health disparities for the first time, right? So organizations and their commitment to saying, we have a responsibility and a part to do in this. And when you start talking about clinical and translational sciences, at the core of it is to try to basically get from that individual to public health and to those community types of initiatives that actually really do move the needle. Then when we move into these kind of gray areas, this is the individual. What can you do as an individual? Strategies to mitigate your own implicit bias. Self-reflection is really important. Reflecting on one's own personal biases and allowing yourself to be okay with the fact that, you may have been in one place at a particular point, but you're growing. Just like Elizabeth kind of shared, you are understanding certain things about yourself, and you are giving yourself, or as I always say, unburdening yourself from, it's okay that you need to grow and learn in this. And so that self-reflecting, asking yourself, what would your 18-year-old self have said? What would your 28-year-old self have said? I know that at currently right now, even though I'm very cognizant of certain things around implicit bias, there were times when I didn't have the language to speak to what was happening. And we have to understand that the languaging is important for people to understand certain aspects, because if you can't talk about it, if you don't have the language for it, then it becomes really difficult for you to not only articulate your own things, but also to understand other people. So self-reflection is really important. And you can't engage in this diversity, equity, and inclusion work and actually effect the change unless you do that self-work first. And then question and actively counter stereotypes. This is where we have the opportunity, as not only in our professions and our personal lives, but as citizens and as members of our community, to speak up, to question things, and to actively try to counter stereotypes when we see them in practice, when we see them in policy, when we see them in patient care, wherever it is. And many of you may be in forums where you have opportunities to actually be heard. And if you don't think that you do, then help create one. We have to, we have to call these things out, because if we don't call them out as individuals, then organizations, organizations are not, they're only made up by people. They themselves are not real until we embody them with ourselves. So it's important that we act as individuals and then create more of a conscience for organizations that we work for, to say that, this is not okay. We are not doing enough, right? And that we know that we can do more. And it's not about shaming. It's not about, kind of calling people out. It's about inviting people in, right? And so when we get into those spaces where we're willing to have that kind of relationship with individuals, and it does call for some trust, but at the end of the day, I think that if we start with ourselves, then we can push our organization. And then there's this space of both, where we can intentionally diversify our experiences. So intentionality is really important in this work, that we be not only intentional, but we be diligent in our actions, right? In the work that we're trying to do. And then cultural humility and curiosity, being willing to show up today at this webinar to hear somebody talk about this, and being willing to say, to lean into, for everyone who basically put something in the chat, and everyone who, raised their hand and said something. This is all a part of the actions that we can take to start moving towards mitigating implicit bias. So I want to shift here to translational gaps, just to bring it into context, particularly for CTSI. So what I did here is, you can see that I highlighted one particular thing, and this is from the organizational strategies, meaningful diversity training and mentor programs. So what we have here is from T0 to T4, looking at translational process. And what I'm showing with the errors here is actually some gaps. So between, if you see the first arrow here is between T1 and T2, we can have some of these trainings, but the fact is that some of the trainings that we're having are not necessarily having impact that they should, because they're kind of missing, let's just say, missing certain points. So from here, it's increased awareness enough is not sufficient. So when we're trying to move from T1 to T2, we got to do more in the training. Awareness, the awareness is great. We got to start with the awareness, but that is not sufficient. So then when we move over from T2 to T3, that what we might find here when we're doing that, moving from translation to patience to translation to practice, that we might have situations here where the actual versus intended goals are not necessarily aligning. Because what we may be seeing here is we may be focusing so much so on the trainee themselves that we forget about the patient outcome goals. And so the idea here is that when we start looking at training programs, to ask ourselves, as we are moving from one stage to the next stage, what is in those white spaces, those gaps? What might we not be connecting? And then down here at the bottom, when you see from T1 to T3, which is from translation to humans to translation to practice, what we have here is a gap where providers' implicit prejudice manifests in their communication behaviors during medical interactions. So that's where we want to try to basically close the loop. And what's really important is that as we create these diversity trainings or these mentoring programs, that we keep focused on sort of what we're trying to move through from one stage to the other, and that we have real explicit learning outcomes that are aligned with what we're trying to do for that particular phase. For example, at T3, we're trying to evaluate the effectiveness of training. So if we're having a gap between T1 and T3 here around basically these particular manifestations of communication behaviors, then we should have some trainings that are focused on that. So let's have some trainings that push from awareness to say that, okay, now this is the goal here. The objective is awareness. Now, what's the next step? I know that early on when I asked you to put in the chat about the association, I'm gonna go back in the chat. Some folks put some things about the implicit association test. And I think that there were some comments here about it being thought-provoking. And then there was some that it was a good experience, was what I expected. And then I think that Catherine had put, I thought the follow-up screen was interesting because it asked if they explained the results well in a way that we understood. So I think that one of the things that you could do, even just from that one experience of, or one or two experiences, and for those of you who have done it a long time ago, I would encourage you go out there and take one again, make it, get it top of mind, refresh it. You may find out that you moved the needle in a certain way, and you may find out that as the test comes back with its results and explains it to you, you may be surprised at what it tells you. And then we can use those types of things there to then start to say, what is a meaningful diversity training? When we start talking about improving the quality of care for patients from marginalized groups, be razor sharp focused on what you want to achieve, and make sure that those learning outcomes and those competencies that you're trying to help people build are actually focused on what the ultimate goal is, and looking through and at these particular translational gaps. So I want to stop right there and see if there's any reflections on that, any questions or comments that anyone wants to share about translational gaps or experiences that they've had with diversity trainings, and how did they hit the chord? Were they voluntary? Were they required? So anything. So I appreciate if someone would come into bring their voice into the room here, and perhaps share about, because this is at the organizational level. Okay, I'm gonna let you off the hook here, because pretty soon you're gonna be going into your breakout rooms, and you may not be talking to me, but I hope that you'll talk to each other. Okay.
I don't mind sharing. I found the trainings from Reverend Dr. Bryant Marks that we have access to here at USC to be the most effective that I've had so far. Highly recommend.
Catherine, what can you share? What were one of those trainings about? What was the kind of topic area?
Yeah, it was an all day on implicit bias. And many of our schools at USC have had Reverend Dr. Marks in to do those trainings. Business school, School of Social Work, and he'll be presenting again at our Provost's annual Diversity, Equity, and Inclusion Awareness Week.
Excellent. I think that having a day-long implicit training is great. We in a matter of 2 hours here, we just try to cover on some high points or whatever, but I think some deep learning and opportunities like that are really beneficial. And I know that even diversity, equity, and inclusion colleagues of mine, some who are chief diversity officers, they retool up, they re-enter into these trainings and are constantly revisiting them, because we're learning more. More studies are being done, more data being done, and also there's a lot of opportunities to think about it in your particular context. So thank you, Catherine, for sharing that. Thank you, Diana. I appreciate you. So locating inequity in CTS, I think that the important thing here is that we're dealing with inequity, health inequity, but we also have healthcare inequity. And thinking about how equity and inequities play out in those two very different contexts. I like for you to just make sure that we're kind of holding that. Inequities can be operating at very different levels. Okay. So as we get ready to move into into the breakout, I want to cover this notion of equity mindedness in clinical and translational sciences. So here's three, these are gears, 3 gears that are kind of operating and moving together. One kind of pushes the other, and you kind of want to get all these gears moving. We want to be race conscious. We want to be systemically aware, and then we want to be equity advancing. And on these different notions and race consciousness, right? We want to be able to really be aware that that many of these things that we deal with have historical and social context, which are long-standing of prejudicial attitudes and discriminatory behaviors. We want to look at that at each stage in the translation process, deconstructing that at each stage, because there's some things that are going to be let's just say present throughout, and then there's going to be some things that are more present at certain stages, and understanding it from who are the entities that are involved. Is it direct patient to doctor care? Is this about something? Is it at the clinical trial level? So really trying to understand sort of where it's at, and then being very conscious about how race is playing out in that context. Then there's the notion of being intentionally and positive, having intentionality and positively impacting sort of this systemic and avoidable. We say avoidable because from an equity advancing standpoint, we're trying to get to this unjust difference. And here in this particular context in healthcare access, utilization, quality, and outcomes for different groups. And being systemically aware means that we understand that this is not a matter of it's just this individual, right? It really rises it up to the levels to say that these health inequities are systemic, that they're dysfunctions of structures and policies and practices, that actually help lift up and, facilitate structural racism. And that structural racism is a fundamental factor to health disparities. So when we move in this kind of equity-minded way, we put equity in front. We say that we're trying to always ask ourselves the question, is there a difference here? And why is there a difference? And is that difference, is it justifiable or is it unjust? So in this sense, equity-mindedness in CTS is about justice. It is about trying to be socially just within this context that we're talking about right now in clinical and translational sciences. So keep this, the equity mindedness is really an important concept when you're talking about, moving from implicit bias and moving from unconscious bias to this space, because when you become equity minded, you're saying that equity is top of mind, right? And now you're moving into the realm where it's no longer underneath that surface of the iceberg, and now is up above the water. It's that part of the iceberg that's actually poking its head out, right? Yes, you're so right, Makisha, in that notion of the iceberg analogy, because it may be that before we were dealing with just a very small part of the iceberg on the top of the water and so much underneath, and one could argue that berg is becoming more buoyant and is actually lifting up, and we're starting to see what has been under the surface starting to come to the surface. The question is, and what will we do about it? Right? So like I was saying earlier, awareness, we got to push that. Awareness is not enough, and we have to get to that action step. So here's what we have as we're moving into a breakout. And I have you for breakout. It's now currently 4:04, so we'll probably break out for about 20 minutes, and Karen's going to help us out and break you out the room. So let's start first before we go into the breakout of what I want you to talk about. So I have here on the screen some data for you, right? And we're going to talk about leveraging racial data. So this is some data here. And what I like for you to do in the breakout is to reflect on this and have some conversations about this as it relates to whether that comes from your own lived experience, from your professional experience. All experiences matter as we're trying to basically to push ourselves and to try to basically understand this more diversified perspective. So these data show us here that, and I have a link here to this health dashboard, right? And so there's a number of racial and equity health dashboards out there. This is a pretty good one, and you'll have this link in the presentation. I encourage you to go out there if you haven't been on this particular dashboard. But here's some things that I pulled out from it. That the percent of adults reporting perceptions of and experiences with unfair treatment in healthcare. I haven't provided sort of what the conclusion was, because I want you to come to the conclusion as you look at these data here, to kind of take them in. And then the share of adults who reported that a doctor or healthcare provider did the following in the last 3 years. So on this one, you see Black, Hispanic, and white, and a percentage of didn't believe they were telling the truth. Refused to order a test or treatment they thought they needed. Refused to prescribe pain medication that they thought they needed. Catherine, you talked a little bit earlier about this. And then Markeisha, I know you talked a little bit about this not being believed or trust factor. Over on the left, when we talk about the healthcare system, here's the data on healthcare system often treats people unfairly based upon their race or ethnic background. The question being asked, this is what the individuals in those particular race classes said. And then the second one, personally treated unfairly based on race while getting healthcare in the past year. I also wanted to add in here a finding from a study. It said Black women overall are more likely than Black men to report feeling that a healthcare provider didn't believe they were telling the truth, assumed something without asking, or suggested they were personally to blame for their health problems. So here, this is really loaded, because you have basically the racial data, but I've actually provided you a statement too to say that when we look at intersectionality, when we start to bring in gender, and then when we start to bring in even socioeconomic classes, we may see some differences between those particular individuals within the race class. In this particular statement here, 3 things, right? You're not telling the truth. I'm making an assumption, but didn't ask you, and that I'm already blaming you for your particular health problems. So what I'd like for you to do as Karen gets ready to break you out is just have some conversation about sort of, these data and other data that you may have engaged in that similarly situates these non-white individuals or groups of individuals in certain particular states. Let's see. I want to also allow you to think about, some of you may need to take a break or step away. So we're giving you enough time in your breakout in case you need to step away a little bit. We'll come back from the breakout here at let's see, 20, at about 4:30.
To that doctor that is not believing their patient. And I think I asked the question is, why would they even question that? And she said it's because of the bias, and I said maybe it's just really because of racism. I mean, it's still alive. So yeah.
Yeah, I mean, you bring up some good points, and particularly just harking on the point of the historical context of certain things, right? So one of the things relative to the unconscious bias that also then moves into a realm of implicit is that we often don't understand how certain prejudicial attitudes that get to stereotyping and then turns into discriminatory practices are associated with long-standing beliefs that came up out of certain contexts and situations. This notion that certain people have a higher threshold for pain, and not that the individual had a choice, right? It wasn't even, so then when having a choice, so then maybe moving forward, then one might assume that if you couldn't possibly be in that much pain and not have come in, right? And so it all kind of layers, it's confounding. And that, you know, when we go back to that Episcope, there's notions of how things get confounded, and have to be, you know, that confounding aspect means that we have to unpack and disentangle some of these things to actually get underneath of them and shine light on them. And then to your point about your colleague that you were talking to, what do you do? What do you say in that moment when you are witnessing what you perceive to be a discriminatory practice or stereotypical behavior? And often we're embedded in these power structures where, you know, I can't say anything, right? And so this is one of our challenges, is that, you know, why can't we speak up about these things without retaliation, right? What I find interesting is there's all these things we have embedded in our, let's just say, human resources, where a person can say something happened to them and we have to investigate it, right? And we can't retaliate, and we have to take the employee's word. We do the investigation, right? But in some spaces, it's accepted and no one does anything about it. So I appreciate y'all sharing that.
Mm-hmm.
So let's move into this, because this might encourage some other folks maybe to speak up, because I really want to go into this notion of algorithmic equity, right? What we know is that often what is operating in many spaces are algorithms that are embedded in systems and tools that kick out certain things that then shape the attitudes and the actions of individuals who are the recipients of that information, and then are called upon to then make decisions or to enact certain practices because of it. And this idea of algorithmic equity really hones on the points that we take our biases and we embed them in systems. We put them into models, we put them into predictive analytics. As a former programmer, I imprinted my attitudes and my beliefs in the programs that I wrote, right? If, you know, a program that I wrote would basically, you know, have error checking based upon what I believe to be certain users' behaviors, right? And so then when you start to do something that is as powerful as that, this is going to determine whether some people are going to be perceived as being treatable or have access. And a lot of this happens in these algorithmic equity. I have colleagues who are basically actuaries and do a lot of basically algorithms trying to train predictive models and everything to kick out various things. So I want you to be aware of this, and how what we need to get algorithmic equity is that we need more accountability for these models. We need fairness to be embedded in them, and we need transparency. And one of the things that the authors of this particular paper that's cited on this page talks about, and some other ones, is the closing the loop, the community partners. You know, who are these algorithms going to impact, and how do we engage you know, individuals that are going to actually be impacted the most by some of these outcomes, in actually thinking about reviewing, evaluating, and training these models with more data. Okay, so I want to share two studies with you in this regard. One is some research here, potential biases in machine learning algorithms using electronic data, electronic health record data. So some of the findings here, as you can see, is that we talk about, first of all, that that machine learning algorithms may be subject to biases, right? And that data used by these, you know, algorithms may contribute to socioeconomic disparities in healthcare. Biases could be introduced into these machine learning based clinical decision support tools. And that, you know, we are seeing, because we're such, you know, our society is becoming so technically bent, that there may be an over reliance on automation and algorithms based on biased data and algorithms that do not provide information that is clinically meaningful. So I want to stop right there. Any thoughts about this one here? Machine learning algorithms and various algorithms that are used in the healthcare system. Anybody in the course of your particular professional or research responsibility using various algorithms for different aspects? Anything you want to share on that?
Hi, it's Renata. I actually work in Alzheimer's disease research, and we have a lot of studies that use assessments where they ask different questions to the participants in these studies. And it has been conversation that some of the questions that are asked might not, what I want to say, they might not relate culturally to Blacks, you know, the same way as a Caucasian person, and it is affecting the testing scores that come back that is now used in the data for these studies. So it's definitely an important conversation to have.
So one of the things to keep in mind, you know, I work with a number of folks who are data scientists, and one of the things in trying to help individuals, there's often, you know, this aversion for some folks. They don't have, you know, this strong mathematical or statistical type of trainings or backgrounds or whatever, and you know, in some ways that keeps people at bay. Right. And so what we have to think about there is that this notion of transparency and fairness and, you know, accountability means that, you know, you don't have to be a data scientist to actually interrogate sort of the algorithms or the predictive analytics that are being used to actually get to certain decision points. You can ask questions. You can try to understand sort of like, so how's this decision being made? What are the factors being used in this particular, you know, tool? And I think it's really important for us to, you know, to interrogate these types of things, because, you know, there are many algorithms that are getting it wrong. It's getting it wrong, and people are being harmed because of it. And I think that, you know, it's really important for us to lean into this. So let me share this next one with you, because this is really relevant to that point. Algorithms deployed on large scales are typically proprietary, making it difficult for independent researchers to dissect them. Researchers must work from the outside, right? So when you have basically, you know, private industry that creates these things, and they basically, you know, kind of stamp their proprietary, you know, oversight over them, then it can be hard to get at that. And then when you have these things being used across healthcare systems to decide, you know, this, that, or the other, then it becomes more difficult for us to really do something about it. And this is the notion of that we need more transparency, right? And then this particular study, which is dissecting racial bias in algorithms used to manage the health of populations. One of the things it talks about is the growing concern that we may be reproducing racial and gender disparities, right? By how data is being labeled or how that data is being trained, right? So algorithms learn from data. The more data you give them, they learn. That's training the algorithms. And some of these algorithms are not being trained deeply, or they may not be trained appropriately. So what we're finding is that, you know, we need to make sure we understand how these algorithms have been trained to come up with the outcomes that they're putting out, right? And so this particular study talks about, you know, bias being attributable to how the data is being labeled. And here it makes this distinction between what might be an unobserved optimal prediction, meaning that, you know, something is predicting this without observation, and then how that might be different when the prediction of an algorithm is trained on something that is an observed label, and saying that this is a useful framework to try to understand biases in algorithms. How was this algorithm trained, right? And we need individuals who are in the areas of data science, actuarial science. We need those individuals to get trainings and to have trainings around implicit racial bias and understand these things, because just being sort of the data people is not enough. We need more individuals with diverse perspectives and diverse understandings to actually interrogate machine learning, artificial intelligence, and our algorithms and predictive analytics that are impacting our health system and ultimately patient care, and which may be ultimately resulting in some of, perpetuating health disparities. So I just said a lot right there. Any reactions to that? What I would add to this is that I'd ask, sort of the question, do you know how algorithms are shaping and influencing your life, influencing your own health care, right? I think that this notion of cultural humility and curiosity, trying to understand certain things, and we can always start with trying to understand something that's a little closer to us. Maybe it's you, maybe it's a family member, maybe it's a colleague, but I think it's really important for us to think about, the responsibility that we have to actually get these types of things more understood by communities. So I put this here, relative to maybe adding to the chat. Algorithmic bias in communities, right? We need to figure out how this is another place where we're not necessarily closing the loop and helping communities understand how decisions are being made that are affecting them and populations of people, and they don't necessarily know this. I mean, if it's proprietary, that's one thing. But what about in the public health sphere, when we have entities that are being funded by granting agencies, universities who are supposed to be operating for the public good? And I think that this is an area, algorithmic bias, that I think necessitates some, deep research across disciplines to try to understand. And social sciences can bring something to the fold here. I think that participatory action research is one way of getting at that, when you bring, those who are being affected together as co-researchers. Is one way to try to get at some of these things. But this is when we start talking about technology, we need to understand artificial intelligence, machine learning, and predictive analytics are going to be more and more important for us to layer into how we might see some of those gaps in the translational process in between the various stages. And I also would say that if we look at what's happening in higher education, you're seeing more of these degrees programs coming up. At first we used to see health informatics, and now, we move from just informatics and analytics to now we're getting to science, health data science and things like that. So these are things for us to really pay close attention to. And then it makes me wonder too, how we might be thinking about the curriculum that we're developing for those who are going through medical school, and what's happening with those who end up in postdoc fellowships or in residencies, or those who are looking at more of being a researcher than being a practitioner. It's going to require all of that. So any reactions to that?
Dr. Snowden, oh, sorry, I'm gonna let Elizabeth.
It's okay. It was something we talked about in our group. It was about how, if we get to ways to understand how to make this better, how do we measure success in that? And, whose perspectives are important. And I think this is one of those really complicated problems that I think you're doing a great job of breaking down into pieces to think about in, separately. But it's also like what, how do we know that the algorithm's doing better then? Do we measure an individual algorithm's output? Do we measure, change in society? It just gets like slightly overwhelming as I like try to think through some of those things. I don't know if you have suggestions on that, but
well, Elizabeth,
yeah.
I think that what you have to do is that you have to bring more diverse perspectives and folks to the table. It is a large and daunting task when you start thinking about, what you need to do. But what we know what we've learned in diversity, equity, inclusion trainings is that there's a lot of trainings that have been done, but there hasn't been enough evaluation or assessment as to whether they're having an impact. Right? So if you're going to, we know this as researchers, if you want to get a grant or something, you got to have the evaluation and the assessment part, right? You can't just have that we're going to create the training. You have to have, and how are we going to know that this training is having an impact? And I think that when we start talking about these big algorithms, the first thing that we have to do is we have to understand what's operating in the public sphere and what's operating in the private sphere, right? What has been privatized? Many of these algorithms have been privatized and made property, of private industry. And then for us in the public sphere, when you start talking about having to impact or to affect public health, then how do you get at that? And I think that, is first what we say is awareness, right? And then moving from that awareness realm to the action realm. So it's something, Elizabeth, it's a big task and it requires, this is when you need to have those discursive moments when you bring together, people across various fields to come together and say, how do you tackle this problem? What I've come to understand and appreciate about what I've learned just from just a brief interaction with clinical and translational sciences, that it really is about trying to get at that. So I think that one article that talked about how this could be used for a framework to even interrogate it, it layers it in. So, and I know that we're just here about time. And so I just have one last slide, and it speaks for itself. But I will call out structural impact. This is what we're trying to have: equity at every level. And I love this, this diagram, which I did not create, but when I saw it, this notion of transforming conditions in which people are born, grow, live, work, and age for optimal health, and seeing this at every level, the base of it being a healthy society, and on that, a healthy environment built on top of that, and a healthy community and healthy people. And as we see these things on the side, right? Discrimination and minority stressors, we see that here in the bottom right-hand corner. But this is systemic. Today we're talking about, in this particular, time that we had together for this 2 hours, we were talking about implicit bias, conscious, unconscious bias, algorithmic equity, racial bias and everything. But ultimately, at the end of the day, if we're going to try to have the type of impact and the change that, Elizabeth, you were just calling for what can we do about it, it's about how do we have structural impact. And the only way that we can do that is to think about equity at every level, right? At every level. So I want to be mindful of the time, respectful of your time, and thank you all for hanging in here with me. For this, this time together. There's so much to know and so much to learn. And I always learn a lot from individuals who share. So I want to thank you all for who's leaned in and shared and put stuff in the chat, and even if you didn't have an opportunity or didn't feel comfortable sharing something, I hope that you take something away today. And whatever you take away, I hope that you think about what can you do differently because you've got that one takeaway. Okay. So thank you so much for your attention and your time today. I know that you know, it's a busy life for all of us out there. So I really appreciate you taking 2 hours of your time and coming to this webinar today.